Good evening. I'm Steve Glassman from the Leatherman Spine Center in Louisville, Kentucky, and it's my pleasure to welcome you all this evening to the second combined SRS SOSORT webinar. Tonight's webinar is going to be on adult spinal deformity. Our host, who I'd like to give credit to for organizing this, Joe O'Brien, is unfortunately having a little bit of technical difficulty. Hopefully we'll get him in a little while. But in the meantime, I'd like to welcome everybody to the webinar and get things started. Our speakers tonight are an outstanding group from around the world. They include Fabio Zaina from Milan, Jean-Claude Mauroy from Lyon, Larry Cohen from Sydney, Australia, and I'm in Louisville, Kentucky. Our moderators are Joe O'Brien from Boston and Sabrina Donzelli.
Ladies and gentlemen, good morning, good afternoon, good evening, according to where you're settled down. I'm Fabio Zaina from Milan. I'm actually a physiatrist, and my field of expert spinal deformities. And today I'm going to present you an overview of this problem. So first of all, what is a deformity? A deformity is a malformation of the bones, of the shape of the body. And in our setting, when we speak about deformity, we speak about deformity of the trunk, so the spine and the thorax. Just to give you an example, this is what a deformity looks like. You can see this old lady with this very asymmetric posture, with an imbalance of the shoulder, a shift of the trunk to the left, and a big prominence on the left part of her spine. This is a deformity that is not actually only a posture, but a change that occurs in the bones and can be seen also from outside. As you can see here, this is the X-ray of her spine. She has this anomalous curvature of the spine, which is actually a degenerative scoliosis. You can see it here on the left part of the image. And you can see also on the right side that the profile of her spine is not normal anymore. So the problem is that these kind of deformations are really frequent during adulthood. You can think that during adolescence, only 2–3% of subjects have some deformation, while up to 60% of people with 60 or more years of age have some kind of deformity. The problem is that deformity can have an impact on life, on quality of life mainly, and this is why we are here tonight to speak about. Describe better the deformity and thinking about mainly about scoliosis, which is the most evident deformity during adulthood, we can use the EBI classification that classificate scoliosis in 3 groups: type 1, which are primary degenerative scoliosis; type 2, idiopathic scoliosis that are progressing during adulthood; and type 3, which are secondary degenerative scoliosis. What are the differences? Well, type 1 is a scoliosis called also de novo or degenerative scoliosis, is usually in the lower part of the trunk, in the lumbar or thoracolumbar area, and is characterized by a quick progression of the deformity year after year, and is significantly associated with pain. It's caused mainly by a degeneration, usually of the discs and the facet joints. Type 2, which can be both thoracic or lumbar, and usually it's combined with a secondary degeneration or an imbalance of the trunk. Kind of scoliosis are usually scoliosis diagnosed during growth that at a certain point during adulthood tend to progress. Type 3, which is divided into 2 subgroups, 3A, which depends mainly on problems outside the spine, like an oblique pelvis due to a leg length discrepancy or a hip pathology, or other secondary curve in idiopathic or neuromuscular or congenital scoliosis, and other asymmetrical anomalies in the lumbosacral joint. And then we have the type 3B, which is connected to metabolic bone disease, mainly osteoporosis, that can be combined with other asymmetric diseases or vertebral fractures. But what is the natural history of these deformities during adulthood? What are the problems for subjects affected by this condition? There are some well-known possible problems that can affect each single subject in a different way. There is a risk of progression, risk of back pain. There can be breathing problem, social and psychosocial impact. We will speak also about mortality and pregnancy. We must say the data we refer to are mainly coming from the Iowa study, which is a cohort study, follow-up for a long time, 40 to 50 years, both to assess the issues connected to the deformity and the risk of progression. The cohort is not so big; it's about 100 of patients, but it's the most the most significant and long-term outcome that we have today in literature. About life expectancy, we must say that scoliosis is not a life-threatening condition, despite the risk of quality of life impairment. The expectation in terms of life is exactly the same as of those people who don't have scoliosis at all. What can affect patients then is a flexed posture that can develop year after year due to a progressive postural collapse that can then become a real structural condition. This can impair a lot the quality of life, because when you're totally unbalanced and forward flexed, it's a problem also to move around. You have a reduction of your stability, and this is a quality of life problem. Another well-known issue is connected to the breathing function. Actually, up to 30% of patients refer some breathing limit, some shortness of breath that can limit their activity, and only 2.5% have a real dyspnea. And it's well known that these problems correlate with the severity of the curve, mainly in the thoracic part. With respect instead of heart problems, these are relevant only in very, very severe curves of more than 100, 120 degrees. And usually this is not a problem for this kind of scoliosis. A big issue is always connected to pregnancy, because many women are afraid of pregnancy or for the possible risk of progression or problems to the newborn baby. Actually, we must say that according to current data and literature, there is no evidence that pregnancy can produce a progression of the scoliosis. And what is instead well known is that there is a risk of back pain, and back pain is one of the significant problems during adulthood. Why? This is due probably to the imbalance of the sagittal profile of the spine, which we know is connected to the stability of the spine and the quality of life. The typical back pain, which is not so strong, is not so terrible, is usually on the apex of the curve or on the convex side, or can be between the scapulae. Usually there is a relief of the pain while lying on a bed, and only in rare occasion is a reason to go to a physician for an assessment. Then there is also, we said, the risk of progression. Usually when curves at the end of growth are below 30 degrees, there is not really a risk of progression, but this increases when the curves are more than 30, and very relevant when they are more than 50. Just to give you a couple of details, the Cobb angle here is the sum of the inclination of the vertebrae on the horizontal plane. This makes the Cobb angle. So if you look at the two red lines in the bottom of the spine, the sum of the inclination on the horizontal plane, this is the Cobb angle. This is what we measure in X-rays. But what about treated scoliosis? According to this graph, we can see that only large curves have a real big risk of progression. You can see the red line. These are the curves larger than 45 degrees at the end of growth. These have a big risk of progression, while the other ones, the smallest one, have a risk of progression similar to those fused, those operated. No difference for late onset and early onset scoliosis, so those diagnosed before and after 10 years of age. One of the big problem in all the kind of spines is that the degenerative processes tend to unbalance the spine in a forward flexed posture, and this needs a higher activity of the muscles of the spine to be supported, and then this leads also to an imbalance in the lower limb that tend to flex at the level of the knees, the ankle, and the hip. And this is not a good way to face the worsening, but if without the treatment is the only way that we can try to find a new balance. a quick look at the goals that we have. The main goals are to improve pain when present, to improve quality of line, and to avoid progression. And which are the main approaches, the possible approaches? Exercises, bracing, and surgery are those usually applied with the summarizing evidence. And my colleagues today will give you more details about. In conclusion, scoliosis is not a life-threatening condition. Progression and respiratory problems correlate to the curve size, while back pain correlate to the sagittal alignment. And it's possible to treat these conditions, but we need to personalize the approach.
Thank you to the SRS and SOSORT for inviting me to present. As you've heard, I'm a physiotherapist in Sydney, Australia, and I'm currently doing my PhD at Sydney University on anterior sagittal spine deformity. Now, when we have adults presenting to our physiotherapy clinic, we can classify them to 5 different categories. We can see a young adult who comes in, and we'll treat them typically as we would normally anyone with an idiopathic scoliosis as an adolescent. We can see adults coming in when they're much later on in life, when they're much older, and they've had the diagnosis of scoliosis when they were a teenager, and it's progressed later on in life and they've come in with some form of deformity. They could have de novo or degenerative scoliosis that we've just heard from Fabio. They might come in post-operatively with a fused spine, either an elderly patient who's had previous Harrington rods or someone younger who's had the new types of spinal fusion. Or you might even see someone coming in and if we look at their X-ray from the back, they have a relatively straight spine, so they don't have a typical diagnosis of scoliosis. But when we look at them from the side, there's the forward stooping posture, which is what, as Fabio called, anterior sagittal imbalance. And it's these forward stooping postures which is most commonly associated with pain and reduced quality of life. Now, these patients might come into our clinic and they might complain of one or many of the following symptoms. They may have pain, they have reduced movement tolerance, they might have deformity, or they might have concern about progression. So it's one or many of these different symptoms. Now, it's important to note that there's no evidence to indicate that non-operative management is able to reverse, correct, or cure adult scoliosis curves. So if your primary problem is a worrying about the size of your curve, then non-operative management is probably not for you. You need to visit with the spine surgeon. So though we can probably involve some form of correction of the posture, the spinal curve in an adult is probably not necessarily going to be corrected through non-operative management. Now, there's very little evidence that alternative bodywork therapy, such as massage, acupuncture, Pilates, yoga, traditional chiropractic treatment, is effective in the long-term management of adult scoliosis. They may help temporarily with pain, but not with the long-term management of scoliotic deformity. And similarly to that, there's also very little evidence that walking alone is effective. So we have patients that come in, they've been told by their surgeons or doctors that they should just walk for their back pain. There's no evidence to show that walking is effective in management in chronic lower back pain or in spine deformity. Now, what's the role of the physiotherapist in treatment of adult spine deformity? The physiotherapist should be considered part of a multidisciplinary team, and that team should consist of the general practitioner, a spine physician, a spine surgeon if indicated, a bracing specialist if indicated, a pain management specialist if indicated, and we will all work together with you, the patient, to achieve the best quality of life outcome for your particular case. Now, there's little evidence to suggest that quality of life is associated with the severity of the scoliosis curve. So we can have patients come into our clinic with very large curves and not too much pain. And we have some patients come in with small curves and lots of pain. So the size of the curve is not necessarily associated with pain or reduced quality of life. Now, historically, there's poor evidence to support traditional physiotherapy in the treatment of adult scoliosis. And Dr. Glassman, who will talk later on, was one of the primary authors of a very important paper in this field. Now, what's the role of the physiotherapist? We heard is to be part of the team approach. Now, there's been some more recent evidence that has confirmed that there's poor effectiveness of traditional physiotherapy in adult scoliosis treatment. However, more recently, when we have a slight modification to the traditional physiotherapy treatment, there has been some positive impact on scoliosis. Here's a study using an Italian-based approach called CIAS, which shows that there was a slight reduction in carb angle in a group of adults who underwent this particular treatment. And more recently, there's been a randomized controlled trial showing that this particular modification to traditional physiotherapy treatment has improved pain and movement confidence in these particular patients. So these modifications or adjustments to traditional physiotherapy are called physiotherapy-specific scoliosis exercises, or PSSEs. Now, there are 7 schools or families of PSSC treatments that have been accepted into the Society of Orthopedic and Rehabilitation Treatment for Scoliosis. And there are 4 similarities to these different schools of treatment, and they all involve a 3-dimensional autocorrection. They all involve some form of training activities for exercise as well as activities in daily living. They work on stabilizing the corrective posture, and they often include some form of education. There's been a recent evaluation of the effectiveness of PSSCs in adult spinal deformity, and the systematic review found the article by Monteconi, which showed that there was improvement in cognitive rehabilitation and pain. More recently, there's been a pilot study on Schroth exercises, which is a German technique, which has shown improvement in calf angle as well as vertical alignment, which is the ability to stand up straight. Now, although surgical management is often necessary, there have been some publications stating that when you compare surgical outcomes with non-surgical outcomes, there has been some effectiveness of non-operative care with regard to pain and deformity in these patients. Now, I'd like to present a clinical case. Here is one of our patients who attended the clinic. She was diagnosed with scoliosis as a teenager, and this is much later on in life where she presents with pain. She did see her spine surgeon who wants to trial a course of non-operative management first. You can see that she has a typical right thoracic left lumbar deformity, and we develop or choreograph, which is a better term, a 3D correction. We look at the following directions of correction. So we want to try and teach her the tensioning correction to shift the right thoracic convexity towards the left and the left lumbar convexity towards the right, whilst maintain her pelvis and shoulders neutral. Then I want to look at derotating the torsional component. So typically when we see a scoliotic case, there'll be a thoracic rib hump and the lumbar hump, and we want to try and take the right thoracic convexity forward and the left lumbar convexity forward whilst maintaining neutral shoulders and a neutral pelvis. We also want to try and open up the concavity of the left thoracic spine and the right lumbar spine, and we open up the thoracic spine concavities through breathing. Now, some of the schools think that breathing is very important, and I concur with that. And we want to strengthen up some of the muscles in the lumbar spine to help stabilize those areas. Now, what we'll do is we'll show her these corrective sequences and suggest that she does some exercise at home. And here's a position which she can do at home, which will utilize a postural correction, and she can work on all 3 dimensions simultaneously. So we can, she can rest with her arm up on a table or a shelf, and she can work her to a postural correction of the sideways corrections, of the rotation corrections, and open up all the corrections simultaneously, whilst activating her muscles as strong as possible to hold that particular correction. We look at education apart from the 3D correction. We want to teach the best achievable and sustainable profile. We want to discuss activities of daily living and basic techniques. So some of our patients need to recognize that they might feel better in the morning, and that's when they should choose certain activities to do at that particular stage. They might need to rest in the afternoon to recover if they have any issues. Not only do we look at the mechanical or the spinal component, what's going on, we also need to look at the psychosocial component, and that involves something like cognitive functional therapy and recognizing the contribution of the nocebo towards their ongoing pain. So here's some research that we did through Sydney University. So we know that scoliosis is typically identified by looking at the spine from the back, but we also want to know what the correct sideways shape of the spine is. So we evaluated 250 adults from the general Sydney population, and we identified that only 20% of them could recognize that the correct shape of the spine should be S-shaped when viewed from the side. So I'm going to use my mouse, and you can see that this particular image. So the spine should have a sideways shift towards the back on the upper back, and a forward shift, a forward curve towards the front and the lower back. And that's the S-shaped spine, which is important when viewed from the side. So we found that our general population, those who did not know this correct shape had a greater spine prevalence, and they also had a greater severity of lumbar pain. And in scoliotics, we need to make sure that not only do we know what the spine looks like from the back, but also what it looks like from the side. Now, when we look at cognitive functional therapy, which is the inclusion of the psychosocial component, not necessarily the spinal component, we want to work with our patients to make sure that they can overcome their unhelpful beliefs, the fear of their back pain, low self-efficacy, they have lost hope, they have maladaptive or provocative movements. So some people do some things with some exercises that actually contribute to the pain, and other patients might do some things that avoid a resolution of their pain. So we can show them some recovery or resting position to help them with their pain. And when we look at the effectiveness of the Monteconi randomized controlled trial, not only did they do CS exercises, but they looked at cognitive rehabilitation to help them with their improvement in pain and function. Now, we also want our patients to recognize the nocebo effect. Now, a nocebo is a detrimental effect of health produced by a negative expectation of treatment or prognosis. So some of our patients come in with large curves, think that their curves are very bad, and they've been told that from the spine physicians or friends that their curves are bad and that will increase their pain. Now, we know from a placebo, sometimes we can give someone inert sugar pill and tell them that the pill will be effective for their pain, and that leads to a reduction in pain symptoms. The opposite can also occur. Sometimes we can give someone a sugar pill which should have no effect on the body, but if we tell them that it can increase their pain, they will have increased pain. So our patients need to recognize that sometimes their curves are not as bad as they think they are, right? And they can overcome a lot of their pain, and we look at exercise and some of the treatments that we do to achieve that. So I'd like to thank you for attending. I'd like to call on Jean-Claude right now, who will discuss bracing as an option. Thank you very much.
Thank you, Larry. We will now speak of bracing, even if bracing is always associated with physiotherapy. Okay. So the first publication was a Greek publication associating Schrott physiotherapy 15 minutes every day with Rigaud-Chenot brace. And we see it was very difficult because we have at the beginning 145 patients, adult patients, and 2 years after beginning of the treatment, it remains only 36 patients. And the results was not very significant because we have 30% of evolution, further evolution. Another study review was done by Josette Bethany, and it was quite nothing about bracing. The first study was a French study from Catherine Marty with the protocol of Paris with the polyethylene bracing. And for the first time, it was possible to prove that there was the angulation was not progressing. We have a stop of progressing of the angulation with bracing. For the first time, to our knowledge, the study suggests that underarm bracing may be effective in slowing down the rate of progression in adult scoliosis. Further prospective studies are needed to confirm these results. So, till now, it was only for pain. The bracing for adult scoliosis was only for pain. And this was the first study with some effect on scoliosis angulation. So I try to do with the same protocol a study of 39 patients and who were coming at the clinic to brace. It was only for bracing, for sometimes for pain, sometimes to avoid surgery or to delay surgery. And we will see the results. I have another slide to see the results. From this 739 patients, we have 89 patients, female patients, and 11% of males. And one first thing was the lower limit vertebra. And we see with angulation, correlate with angulation. And we see that if the distal vertebra is L1, we see the patients at 45 degrees. If it's L3, we see them at 40 degrees and L5 at 28 degrees. So it's normal, but if the lower limit vertebra is low, we have make more problems. This is the repartition of all cases. This rotatory dislocation of Dubousset more than 50%. After we have segmental disc instability. And after we have the kyphoscoliosis, sometimes straight canal, stenosis, lumbar stenosis, and sometimes after surgery, some instability after surgery. This is the age versus Cobb angle. So we see that we have the same number of patients between 40 and 50 years, 51 and 60 years, with the same Cobb angle. So it's not really significant. And it's the same for the scoliosis angulation. Between 20 and 30 degrees, we have a great number of patients. 30 and 40, quite the same, a little less, and 40 and 50, 100 patients. So the instability is not correlate with the angulation. Another result is the repartition of the patients. 62 patients are in treatment. We have only, I think, only 17% of dropout, and 21% were seen more than 5 years after beginning the treatment. And this series, this cohort, was studied particularly 158 adult scoliosis treated with polyethylene overlapping brace, and reviewed at least 5 years and average 8 years after fitting the brace. So we can calculate what is exactly the stabilization of scoliosis for these patients. Next, okay. The principle of bracing is different from adolescent scoliosis. We try to decompress the disc to have a lift effect to avoid too much pressure load on the disc. To rebalance the spine, we are big problems of balancing the spine and to relieve pain. The protocol is full-time during 3 weeks. This was the plaster cast, the role of the plaster cast, and after 4 hours every day, minimum 4 hours every day. But the average of wearing was 6 hours every day. It's necessary to adapt the frame to make both the molding or the plaster cast at the beginning of the treatment to help the patient to correct during the time of the brace. We have dropout 17%. Perhaps the same problem when there is a plaster cast at the beginning. It means that the patients are very motivated. And this is the brace after the 3 weeks of plaster cast, and the bivalve overlapping brace with the lateral closure, which sometimes it's difficult for the patient to close the brace, and it's necessary to open the brace in the front part. That is, we have sometimes some difficulties. So this is the results on the cob angle for these patients. We have 56% of stability, 20% of worsening, not always to surgery, but this part mainly it's necessary to make a surgical treatment. And 34% who are improving better cob angle. This is the results on the occipital axis. We are better modeling the rib hump, but we are worse. We are not able with this type of polyethylene braces to avoid the forward bending, the kyphosis, the upper kyphosis of the spine. So we try to modify the brace using the polycarbonate, the same as for adolescent scoliosis, not exactly the same, it's polycarbonate of 3 millimeters. And this is a case to illustrate this improving of adult bracing. 60 years, 28 years after surgery, very good surgery, but upper decompensation, and this patient don't want surgery. First, my indication was surgery, but she don't want surgery, so we try. It was the first patient who tried the polycarbonate. With scoliosis 83 degrees, kyphosis 70 degrees. The morning she was quite straight, but during the day there was an imbalance of the spine. So this is her result under the polycarbonate brace. So it's like a lion brace. Polycarbonate is very rigid, so we can't open without posterior hinges. And this is the result in the sagittal plane. Very interesting because you see that there is a modification of the kyphosis, thoracolumbar kyphosis projection. And with EOS, we can study what was happening with polycarbonate brace. You see the torsion between T9 and L3 and the good correction of the torsion. The advantage of this brace is that this really detorsion brace. You see also the vectorial projection of the vertebral body, which is better. So now we can not only have an immobilization, but also with brace sometimes correct the curve. Okay, this is the projection in the sagittal plane, and you see that the correction under the brace is maintaining. Okay, so it was okay. Well, this is the correction is maintained 2 years, 1 year and a half after bracing. So it's real, it's working on the spine, and this is the 2 years after making the brace. This is the correction. And to end the big problem of camptocormia, this patient is more than 81 years, and you see that when he walk progressively, he get kyphosis. You see that he is able to correct kyphosis with the hand on the plate in the front part. Okay, it's going. So he is able to correct himself, and this is very important. If we want to brace, the patient must be able to correct in this way the position. On the tights, the video is a little difficult. I don't know. Okay, if you can progress. Okay, perfect. So you see, another thing very important to brace these adult patients is the reducibility. Especially when we want to use the polycarbonate, the patient must lie straight with the head on the table. And you see the necessity. The first, he block the brace on the lumbosacral region, and he lift the trunk to close the upper part. And if this is possible, so he is able to wear this polycarbonate brace, and you see that there is a very good correction of the posture during the day. It's a real correction. This was not the case with polyethylene brace. Okay, thank you for attention.
Thank you. So again, I'm Steve Glassman. O'Brien has come.
Dr. Glassman, yes, I apologize to everyone. I had technical problems, but they're over now. But what I did want to do is, before you begin, if I could just ask the audience to please remember that you are able to post your questions. I would ask you to please keep them brief, and we really don't have time in this particular format to answer any specific questions about your case. We can do that as a follow-up. But in terms of general questions that you see for the other presenters of Dr. Glassman, please post your questions so we can try to get them in and answer them. Thank you, Dr. Glassman. Go ahead.
Thanks, Joe. Okay, so I'm going to talk a little bit about surgical treatment of adult spinal deformity. So this is a big topic. So we're going to focus primarily on lumbar degenerative scoliosis today. And if you think about what leads to effective treatment, a good place to start is with a clear definition of the problem. And you would think that that would be easy, but it's not really so easy, because certainly these two pictures look like lumbar degenerative scoliosis. But what about that? You know, is that scoliosis at all? Is that just mechanical collapse? If you look in the literature, it says the 10-degree curve is scoliosis, but that's really not our experience. Significant deformity, we look maybe at a 30-degree curve. But in fact, for me, it's not really curve magnitude that's the defining characteristic. It's whether the scoliosis influences my treatment decision. So a curve where correction of the deformity is an integral part of the treatment, I think of as lumbar degenerative scoliosis. If you have a patient who has a curve that's just getting in the way of your treatment of their spinal stenosis, I think about that as lumbar degeneration with scoliosis. And that's not really a magnitude related issue. So this is a patient with a pretty substantial curve, but her problem is high-grade spinal stenosis. You see the complete block on the myelogram. And for her, successful treatment is just good decompression without making the curve worse, right? And we can do that with a single level decompression infusion. This patient, on the other hand, is a patient that has a significant deformity, sagittal and coronal imbalance, and successful treatment means changing the alignment of the curve. So I think of that as really lumbar scoliosis. And in selecting surgical treatment, what we're going to talk through a little bit today is who could have a little procedure, decompression only, who could have a medium procedure, decompression infusion without correction, and then a little bit about who might require a significant deformity correction. And the things that are going to guide you are how much decompression do you need, what's the stability, and how much deformity is there. So we typically evaluate these patients by MRI scan, but I think it's really important to remember that for this group of patients, that may not always give you the right answer. This is a group where there's often dynamic compression, and I use myelogram very commonly in this patient population. I think if you're going to not use a myelogram, at least you have to be very sure that you're using good standing radiographs. This is a study we did last year where we looked at 5-year follow-up after people that had a decompression and fusion or decompression procedure when the patient had a scoliosis. patients who had 36-inch standing films had an 11% risk of revision surgery over 5 years. But patients who had only MRI scan before surgery had a 41% revision rate, dramatically higher. And that's because some deformities are stable and some are really less stable. In terms of patients who would need deformity correction, you tend to see a different picture. You see significant curve progression or change in body shape. You see maybe coronal imbalance or more commonly sagittal imbalance. And we know that coronal imbalance can potentially be a problem, but as some of the previous speakers have alluded to, it really seems to be sagittal imbalance that's most frequently associated with symptoms. I'd like to look a little bit at the literature of treatment, and this goes all the way back to 1979. This is a very small retrospective study, probably wouldn't even get published today. 14 patients that underwent decompression alone for scoliosis, and 50% led to failure. And even though this is not the kind of study we would use today, this study really led to how this problem was treated for a 20-year period of time, practically, where this study said that decompression alone might be insufficient for patients with lumbar scoliosis. Now, we've certainly progressed since then, and this is a look from Mark Weidenbaum, a summary of the literature sort of from 1995 to 2006. And there wasn't a lot of literature, but what there was suggested that decompression only would be for patients who needed a very limited decompression, had only leg pain, and had a very little scoliosis. For me, also, if I'm looking for decompression only, I'd like the problem to be mostly on the convex side of the curve, and I'd like single level pathology. Patients who might have a decompression with just fusion in situ without correction, if they need a wide laminectomy, they could have both back pain and leg pain, and they could have segmental instability at that level, but they really would still need to have a satisfactory overall global balance. And my take is also that this is an appropriate procedure if someone needs maybe a multi-level decompression. Patients who've had a prior decompressive surgery and a scoliosis, I generally would not just decompress them again. And maybe most importantly, that patient with dynamic compression. So a different picture on your supine films and your MRI versus your standing films and your myelogram. If we look to what the literature tells us about outcomes, it's somewhat contradictory. So this is now subsequent literature from 2006 on. This is a study from Japan. They looked at 50 patients who had lumbar scoliosis and underwent decompression. You'll note that these are patients who are older, 70 years, with pretty small curves, only a 17-degree mean curve, with decent 3-year follow-up. And what they determined was that curve progression in these patients was no different than the natural history of curve progression for lumbar degenerative scoliosis. And they conclude that these patients may do just fine with a decompression alone. At the same time, almost an exactly similar patient cohort studied in St. Louis with the opposite finding, right? So 55 patients, again, small curves, about 20 degrees, 5-year follow-up. And Dr. Lenke and his group found a higher rate of revision in the decompression only group. And he concluded that these patients really needed fusion along with those decompressions. So what seems like very similar patient populations, opposite findings. This is a study we did with about 100 patients where we just looked at the outcome of decompression and fusion. We add to those prior studies patient-based outcomes, and we demonstrate that this operation yields reasonably good patient-based outcomes, about a 15-point improvement in ODI, with, again, small curves fused basically to allow an adequate decompression. And we concluded that this was effective, but not necessarily that this was better than decompression alone. Just to look at a little bit of literature for larger curves, these would be curves greater than 40 degrees with associated deformity. This is a study from Justin Smith indicating that if the patients had leg pain, that decompression, in addition to your correction of their deformity, was effective and important in relieving their leg pain complaints. This is a study from Keith Bridwell looking at overall at the larger patient population group, 160 patients, now mean 54-degree curve, so much bigger deformity, baseline and 2-year, demonstrating that in this group, the patients who had surgical treatment outperformed the patients who had non-operative treatment. So his conclusion was that surgical treatment for significant lumbar scoliosis could be beneficial. That's pretty good prospective data, but not really high quality data. This is a subsequent study that we are just at the tail end of. It was an NIH sponsored randomized control trial looking at surgical and non-surgical treatment of lumbar degenerative scoliosis. We added to our patient-based outcomes functional treadmill testing, which I think could be important in this population. And what we saw was fairly similar outcomes to the previous studies. Better SRS scores, better ODI scores in the surgically treated patients out to 4 years. Better function on the treadmill test. Again, this is the ODI scores, better function on the treadmill test out to 4 years as well. I think what this shows is that if you have appropriately selected patients with severe enough symptoms, that surgical treatment is a viable option. When you have reasonable but not great literature, you can't really make guidelines. So what you can do is you can do something called appropriate use criteria, where you combine the available data with expert opinion. And the way that works is the expert opinion has to be not just surgeons, but the broad range of people represented here who treat these patients, physiatrists, therapists, medical doctors. And this is called an AUC, an appropriate use criteria study. And the SRS sponsored this study. It was performed by RAND Corporation and yielded really good data. I'm not going to have time to go through it, but I think that this is a reasonable reference to look at the sort of options for treatment with patients with different clinical scenarios. This is the paper in Spine that has the core data. This is also a sort of summary paper that we wrote in neurosurgery, which outlines it a little bit further in terms of paradigms of how you might treat these patients. So that reference may prove useful because it does outline sort of what I just went through previously. And here, for example, would be the treatment for patients with moderate to severe symptoms, including neurogenic claudication, who you might just decompress, who you might fuse in situ, and who might need correction of their deformity. So in summary, I think it's really the decision-making that drives clinical outcome. I think assessment of alignment, standing alignment is really critical. And I think it's always important to remember that the treatment of your patient, surgical or non-surgical treatment, is going to be patient-specific. Thank you very much.
Thank you very much. We appreciate your presentation. And now we have the question and answer session. So if you can continue giving that. Before I ask the first question, I just want to remind you that this webinar will be available at the link that you see here on this slide. And there is an upcoming session on just September 17th for scoliosis in the young child. And we invite you to join us for that. There are a few questions that we've had for patients, and I'll try to summarize some of them because some of them are the same and rather general. But let me ask the first question from Dr. Glassman. And the question was in terms of the long-term outcomes, particularly of fusion, and what your thought was in terms of tethering, BBT, as it relates to that and how it may affect adult deformity later on.
So tethering, just for the audience in general, is an idea of putting in some type of instrumentation that limits typically growth with the idea that you could stop curve progression but avoid fusion. And I think that it certainly has potential. I would say that none of the existing tethering protocols really I think have demonstrated sufficient value for me to feel like I would want to do that. I think the point of the question, what happens if you tether later on as an adult, I think remains unknown. But for me, I'm more worried about the fact that often tethers are put in but not taken out, right? And if you think a tether is going to work, then the idea is you retain motion. So if you're leaving the fixation device in, by definition, that says you don't have continued motion through that segment. Often that's done in the thoracic spine where there isn't that much motion anyway, so maybe you can't tell. But I think tethering is good in concept, but I don't think our technical capabilities have really gotten to the point where you're going to see widespread use at this point in time.
Okay, thank you. The next question would be for Jean-Claude. And Jean-Claude, there's a lot of questions in terms of what is the best brace. Is there one particular brace for adult scoliosis? And with that, I would say there's a few questions about soft brace or dynamic brace and what your thoughts are about that.
Alors, first, the traditional brace for adult scoliosis is a polyethylene brace. It could be asymmetrical. Some Chono, there is in the literature, some Chono brace used for adults. I think when we have a great instability and reducibility, polycarbonate can be the future for adult scoliosis. What about soft brace like the spine core? I think it could be useful to help the physiotherapist, but we have with adult scoliosis big imbalance, and the soft brace is not sufficient to correct the imbalance. And we have also more rigidity than for young scoliosis. So I have not the experience. I try with a short lumbar asymmetric brace, the brace of Pico or soft tissue, but it was not working. In my experience, it's not working, the soft brace.
Okay, thank you very much. Fabio, does one of the, actually two people asked the question, does scoliosis always lead to leg pain?
Yeah, it can happen. It's not really a rule, but it can happen. Usually the pain is at the apex of the curve, or can be on the other side, in the convex side, but it can lead also to some leg length pain, probably due to some traction of the nervous roots. This is probably the origin of this kind of pain. Sometimes there is a degeneration also. You can have some pain due to also compression, due to the bones, to the new formed bone on the roots. So this can be also the origin of the pain, yes. But it's not only this kind of pain.
Joe, can I make a comment about that?
Sure.
I think we see those patients often because the patients tolerate that leg pain very poorly. Patients will tolerate a fair amount of back pain associated with scoliosis and maybe not come visit the doctor. But when they get leg pain, it's tolerated very poorly, so we see them more frequently. So I think we may have a little bit distorted view of how frequently patients have leg pain because they appear for treatment when that occurs.
Okay, thank you. And Larry, there were some patients that were asking about activities of daily living, and specifically they were asking those that had breathing difficulties or even one with a genetic flat back, was there a particular sport that they should think about that they can do in their activities?
Okay, thanks for the question, Joe. So typically when we see any patient with breathing problems, it's important to kind of exclude medical reasons for the breathing difficulties. So they need to work with the treating doctors. That's very important. You need to kind of evaluate whether it's the size of the curve which is impacting their breathing. But as a physiotherapist, sometimes we can teach them positions that may alleviate or allow them to expand their chest or their rib cage much more effectively, and then work with them with dynamic breathing exercises. And we know from respiratory chest physiotherapy that we can improve breathing mechanics and breathing function. So there are some exercises that can be done. As far as what exercise someone should do, what sports are good, there was a recent conference that we attended where there was a presentation that any exercise is good. It's often the more vigorous exercises, the better if the patient can tolerate that. As far as the questions, are there any particular sports which are bad? There have been some studies which have looked at unilateral exercises such as tennis, or so you'd think that if someone only works one side of their body, that might contribute to a worsening the curve, but that was not identified. So with our patients, we often ask them to do whatever sport they can do. I have a preference, kind of personal preference, for symmetrical based exercise of a technical ability. So we, so if it's a young kid, we look at something like a gymnastics or ballet or Pilates. But I think if someone wants to exercise, we recommend any exercise that they feel comfortable doing.
Okay. As a follow-up to that, Larry, are you aware of Theraflex or the PAM therapy? And what do you think about those?
No, Joe, I have to admit I'm not really aware of that, and I feel kind of I can't really comment on that. I'm happy to do some research and follow up with if you have a particular question on that.
Okay, thank you. Actually, I'd like to go back to Dr. Glassman. One of the things that's different than adults is age. And the age factor, the questions were asked is, if I'm considering, if I have a severe deformity or a moderate deformity, should I think about getting surgery earlier in my life rather than waiting till my 60s, 70s, or whatever? And how do we assess age in adult deformity?
Yeah, so it's a good question and it's a hard question. I think firstly, what we look at now more than age is what we call frailty, right? Which is sort of a health adjusted age, because as we all know, some 70-year-olds look fantastic and some look like they're 100. So I didn't use purely a numeric age, but it is always a dilemma for patients who are not quite bad enough that they need surgery, but worry that down the road they'll be worse and it'll be too late for surgical treatment. And although that's sort of inviting as a concept, I really counsel my patients against that. I think that people don't routinely get worse. There are people who get worse, but there are people who get better and there are people who stay the same. So despite the risk that you could be worse and then be too late for surgery, I pretty uniformly tell my patients that if they're not bad enough to have surgery now, then they shouldn't have surgery now. Because you just don't have a crystal ball to know who are the ones that are going to be problematic down the road. And I don't think it's reasonable to operate on a wide group of people because a few of them might have problems down the road. But it's hard and patients are concerned about it.
Okay, thank you. And actually, I'd like to flick back to Larry again. You had mentioned Schroth therapy as a potential. If someone's in their 70s or 75, is that still a good option for them? And another question is not related, but it was posed to you was, what about doing planks? Is planks a good way to tighten the core muscles in the abdomen, et cetera, and in the back?
Thanks, Joe. So first of all, Schroth therapy would be indicated in any age, from adolescent to an older adult as well. But Schroth therapy is only one of the families of the treatment modalities that we use within SOSORT. So whether it's Schroth, whether it's CS, whether it's Dobermed, there's quite a few options available. And if you don't have Schroth available where you are located in the world, then if you have a look at the SOSORT website, you find some form of therapist or some form of treatment modality that might be effective for your particular case, and your therapist will work with you for that. As far as exercise goes, such as plank, we have some patients that we would teach them their 3-dimensional correction, which they would then utilize within the plank position. So most of the exercise that people do, we will integrate the correction into that particular activity that they do.
Okay, thank you.
Such as yoga, such as whatever, including.
Thank you, Larry. Jean-Claude, just in terms of bracing for adults, we have some adults that are experiencing issues where they're very short-waisted and have their ribs coming down into their pelvic. Is that someone that can get bracing for their condition?
Yes, thank you for the question. The problem is to have a restoration of lordosis. As Steve was saying, the problem is the sagittal plane, even with scoliosis for adult people. So this is a problem of the soft base. It's not possible to give lordosis. So if we succeed, you have seen this patient of 80 years, if there is a reducibility, it's possible to give some lordosis with the brace and to help the patient to have a better diaphragm working for respiration and to avoid this tilt of the ribs and the pelvis. So the key point is to give lordosis to restore maximum of lordosis.
Okay, thank you. And this will have to be our final question. There are many questions, and I thank you, but we are over time, and I take apology for that with my computer problems. But the last question I would give back to you, Dr. Glassman, and it is, when you're doing surgery for sagittal realignment, is there any gold standard, or what are you trying to achieve that would say that you have a successful realignment?
Well, that's a hot topic at the moment. You know, there have been formulas and there are surgical planning softwares that will tell you how to restore what is called normal alignment. But that's probably measured alignment from a young person that may well not be appropriate for an older person. And I think a lot of what we do now is sort of oversimplified. We call restoration of lumbar lordosis successful, whereas in reality, where the lordosis is within the lumbar spine is probably as important as the amount of lordosis. So I think we've made great strides towards recognizing that you have to restore as normal a sagittal profile as you can in an age-appropriate way. But I think we have a long way to go in terms of understanding that fully. I would suggest to you the recent work of Pierre Rousselet as being a good guide to how the thinking is moving beyond just the concept of restoring an SVA or restoring overall lumbar lordosis. So I think it's in transition, but certainly trying to get people to a more normal sagittal alignment is the general direction.
Thank you very much. I want to thank all of our panelists for today's webinar. I want to thank all our attendees, co-moderator, Dr. Sabrina Donzelli, and certainly for the SOSORT and the SRS for giving us this opportunity to come together. Again, we invite you to look at the videos at the link that's given on the slide. And for those that are interested, spread the word about scoliosis in the young child that will be given on September 17th. With that, I thank you all and have a wonderful day or evening.